let's start with a simple question. What do you consider high risk within smoldering myeloma? Pete, and we can just.
So there's two factors that you need to look at, disease burden and evolution over time, right? And the current static models all say the same thing. The more of these cells that you have in you, the higher the risk that you're going to go on to active myeloma, right? But we also know that this evolving phenotype, and I think we need to better characterize how we define that. But for those that have, clearly evolving, factors, so the disease is growing over time, those are the high-risk patients as well. So, I use the 22-20 criteria. I think that they're very reasonable at this point. I think no matter where you, side on this particular debate, any new smoldering myeloma patient that you see in clinic, you have to take that deep breath and observe them, over the first 6 months of their disease to see if they're going to declare themselves as a full-fledged active myeloma patient or not. So, and that gives you time to have this nuanced discussion with the patient, does this make sense for you? Does it not make sense for you? So that's generally the approach that I take.
Caitlin?
Yeah, same. I use 22-20, incorporate FISH into it. I think modeling is designed to be a guideline, a model that not everyone fits. We've learned it from functional, high-risk myeloma. We have functional high-risk smoldering sometimes. So the dynamics of the disease is incredibly important. But that's how, I don't have much more to add. That's how I would diagnose them and kind of start the conversations. You diagnose them as a single point in time. And I always say to my patients, yes, the clock started probably quite some time ago, but as far as I know, the clock starts today. And that 2-year clock that we think is the most critical will be started today, and we'll follow you moving forward.
So, Shyam, what are the gaps in the this modeling?
Binod highlighted some of it, I think, which is one is our way to risk stratify, and that goes into how do we decide. I think the evolving pattern is definitely concerning, but is not accounted for in our current models of risk stratification. Genomics is the other one that's, I think, not fully characterized. I think Aquila is a very challenging study. Until Aquila, I was not convinced that any other studies had risen to the bar of saying we should treat these patients early. I think Quiridex, rightly so. I mean, it was the first study. Many of these patients probably had, myeloma or early myeloma. Therefore, it made sense that treatments worked. I think even the ECOG study for LEN versus maintenance was not very compelling. Aquila, on the other hand, is a very well done study, in my opinion. It is, with the limitations of running a large global randomized study, everybody had good imaging. Slim crab criteria was followed. Patients were appropriately monitored, and it does show a benefit to doing DARA compared to no treatment. The challenge I have, I think, is that not all smoldering myelomas are the same. If somebody is very close to myeloma, I would much rather not give them DARA as single agent, because then I worry if they progress 6 months later, what am I going to give them then? Yeah. I would want to give them quadruplet. So therefore, I probably wouldn't treat somebody who I'm worried is going to progress to myeloma in the next 6 or 12 months with a single drug. And then if you're very early on, I worry that I would be exposing too many of those patients to unnecessary treatments for a long period of time. So I still struggle with identifying who is the right person to give Aquila-like therapy. And in centers like ours, where we follow these patients pretty closely, the results of what the progression events are quite reassuring. It's not as if these patients are coming with renal failure in the observation arm are coming. The only concern I have is that is applicable to dedicated myeloma centers where we know what we're looking for. But if you're going to give recommendations for the community, I do think that the Aquila study gives you enough rationale to say some of these patients could benefit from starting treatments, in my opinion. If you're not able to follow them closely.
Yeah, no, I completely agree with what you're saying. We have to be careful, about how we monitor these patients, and in the study, even more rigorously than you typically would be allowed to do in practice, even at a specialized center, because MRI imaging and either whole body CT or PET CT was done yearly on every single patient until disease progression. Marrows every 2 years, labs every 3 months. So these patients were followed very rigorously, and that just does not happen in the real world. And going back to this issue of SLIM versus CRAB, one of the reasons why we didn't see any renal failure in either of the arms is because no one was allowed to get to that, because you had the SLIM criteria, right? So if you had a free light chain ratio that goes above 100, most of those patients are the ones that would be at risk, right, of getting cast nephropathy, and we just didn't see it because the primary endpoint was, SLIM for those patients.
And I think, so I was going to ask this question. So in our general practice, even for that active surveillance patient, I don't think we're waiting for renal insufficiency or bone lesions, right? So we are really reacting to either the SLIM or maybe the anemia. Anemia would probably be the other one.
And that's where the evolving pattern is going to be helpful. And I think we just discussed before is, even if there is still smoldering, but if there is evolving, I think that should raise enough concern. Now the question is, are you going to treat them as myeloma or the smoldering? Yes. I think, in my practice, I've treated as myeloma, because they are already showing the sign that this is going to go to full-blown myeloma. So why to just undertreat them? So but that is a challenge that people have is, even if it's evolving, which that is going to progress in the next 2 years, how are we going to treat it?
Which ICD-10 code do you use when you document on this?
I say myeloma, so it's...
I think this is the right drug. I think if we're talking about treatment for smoldering myeloma, I think this is the right drug. Sagar is not here, right? A 50% attrition rate in the ECOG study of Revlimid because of side effects, lenalidomide, was because the side effects is huge. So I love your balance of trying to think about how can we safely treat people without causing excess toxicity, without causing increase in financial toxicity, which is huge, and still have a future opportunity. This trial I know has been exciting and has definitely been thought-provoking. It has not changed my practice yet because, while I don't believe that people within 5 years are the people at risk to develop myeloma when they're smoldering after 5 years, they're probably not the people who are going to progress. So I think we need to be a little bit more thoughtful about who we choose for these trials. Granted, I understand when they go back and they look at it, the 22-20 people at the highest risk did benefit the most from it. But the SLIM part of it, and particularly light chains, when none of us can agree that light chains should actually probably still be in the SLIM criteria from diagnostic purposes, to have that be the sole criteria that prompted treatment, I struggle with. And I really want to know that I'm saving lives. I don't see cures yet. It's too soon. It's not a primary endpoint. We may not actually get to know that. But if I'm treating a precursor state, I better be curing people.
Yeah, maybe our kids can present that data, with much, much longer follow-up. So, kind of building on that comment, what is your thought about someone who is 78 and has high-risk smoldering myeloma, and they're coming to you and saying, all right, can we do anything right now, versus someone who is, say, 54? Are there differences in how you would approach those kind of clinical situations?
I think the benefit-risk discussion is different for those two patient populations. To Caitlin's point, we're not curing anybody with single-agent DARA, with smoldering myeloma, nor are we curing them, with Cesar-based therapy, with KRD and transplant, or with DARA KRD, to be honest with you. I had patients on Ascent, and they've progressed, since they've gone through their therapy. So in the absence of cure, all we can say is that we're delaying, progression to active multiple myeloma. For a 78-year-old, that may be a highly valuable thing to them. You may kick the can down the road to the point where they may never need to go on full-fledged myeloma therapy. And, going on full-fledged myeloma therapy is a big deal. We're talking about 4-drug therapy. We're talking about a possible transplant. We're talking about maintenance applied until disease progression. Maybe we'll have studies that tell us that we can do it for a shorter period of time. But that is a big deal. And if you can kick the can down the road and never even have to have that discussion, that's a value to some patients, especially for an older patient.
No, I agree. I think because I was trying to say that, even for frail elderly patients, sometimes you choose one regimen and see how the patient handles that and add second or third, right? And DARA is the first choice that you would do for these patients because it's so well tolerated. So I think that kind of patient, and if the patient wanted to do something, I think DARA could be a very valuable regimen. But for 54-year-old, I think that's a total different discussion. I would probably choose him as myeloma. I have a patient in that age who are just want some treatment, but I have been holding up and say, if you need treatment, we'll treat as a myeloma, not like smoldering, just one drug. So,
I mean, I was curious, has anybody given daratumumab? I mean, I have not, although we discussed it, the data has been out for a few months now. I can't think of a patient where I have actively even considered giving DARA for smoldering. For many of the, I mean, I think I'd much rather wait and watch them closely and start them on appropriate myeloma treatments when they need them, is it generally, even for a 78-year-old. But I think you make a compelling case, though. I mean, that is where I might, consider
a good example, and this is, someone that I actually recently put on single-agent DARA for high-risk smoldering. And they did have evolving features, although they were slowly evolving features. So this is a patient, that's close to 80 years of age. They actually have wild-type TTR cardiac amyloidosis with diastolic heart failure related to that, but still very functional individual. They've got terrible spinal stenosis and neuropathic pain in their legs as a result. So we had a discussion. I'm like, we could treat you with single-agent DARA, potentially delay, onset of active disease, for a guy who's probably not going to tolerate 3 or 4 drug therapy that well, right? So that's the kind of scenario where I think it does make some sense.
More niche. Plus, we don't have a formal indication yet. Those
correct.
Those things are still under consideration, and we'll see how that evolves. So for that 54-year-old, will you enroll them on the CAR PRISM trial?
You're watching the HemOnc Pulse Live, brought to you by Blood Cancers Today, a Fermetics property. For more content tailored to your therapeutic area, visit us at www.bloodcancerstoday.com.
No way. I'll say it. No, I think we've seen so much. I mean, we're talking about toxicity, right? We're talking about trying to cure people and trying to limit toxicity, and I'm not sure that achieves either of those goals.
Okay, so then let me ask a more provocative question, because we have some data coming out at ASCO and EHA around this. I think, Pete, you are presenting the data. So CARTITUDE-1, we have now long-term survivorship with cilta-cel, sustained MRD negativity, 5+ years in the late relapse setting. How long of a follow-up on CART4 or CART1, would you like to see? Would you like to see that, plateaued curve before you get comfortable with the idea of offering cilta-cel to a high-risk smoldering patient? I'm just, making this up as a one-and-done thing. You can potentially cure that high-risk smoldering myeloma patient.
So I think 5-year sustained MRD negativity, PET negative, I mean, there is the possibility of cure or functional cure in that group of patients. The challenge that I have, and Binod spoke to this in his talk, the definition of high-risk smoldering myeloma is problematic. And it has to get better if we're going to expose people to the potential toxicities of that type of therapy, even if it's curative. So if you're curing patients, but your non-relapse mortality is any percent, that's a problem, right? So,
especially if you don't know whether they're going to progress or not, you don't have a tool to predict they're going to progress or not. So the non-progression deaths is going to be a big discussion, and you don't want to have that discussion afterwards. So.
If you're curing patients, but 2% of them get Parkinsonism, for example, that's a problem.
I mean, I agree. I mean, whatever the numbers will be, I mean, we'll be all waiting to hear Pete's presentation, I guess, at ASCO. That number has to be balanced by the number of side effects from that same study. Now, you can argue that's a late-line study, therefore, but we cannot pick only the good parts of the study and ignore the others. On that study, 6% of patients had Parkinsonism. On that study, non-relapse mortality in the first 15 months of follow-up or so was about 12, 13%. And yes, those will all come down perhaps in a more modern era, but they're not going to go down to 0%. They are going to be somewhat higher. Together with the fact that we don't know which of our smoldering myeloma patients have progressed versus not, that plateau will need to be in a much, much higher number to justify using this at all. So I don't think that, longer follow-up of those results will necessarily change my practice of enrolling patients on a CAR T study for smoldering myeloma, which I wouldn't do.
Okay.
I think a big question in my mind is when this gets approved. Probably not if, but probably when is how this will be, assimilated into the community. Because then we're going to see patients coming in at that time with newly diagnosed myeloma who may be DARA refractory. They may find at least DARA exposed. How is that going to adjust our treatment algorithm and our subsequent therapies thereafter? So I hope that there are some pretty tight guardrails around the approval, which probably won't be the case, at which point most of the guidelines are going to have to help us with that.
That's totally, I fear that, because I've already been asked by the community doctors to start using DARA for the smoldering. So that would be a challenge. Once they really progress into active myeloma, how does it impact all this excellent data we have with the Perseus and they're already exposed to CD38. Are you going to compromise that, because when they really need the treatment, right?
Yeah.
So
I completely agree with what everyone's saying, and it's going to be important for us as a community to get the education out there early and to do it right. I do think that the community oncologists are capable of having these nuanced discussions. They do it every day of their lives when they're seeing patients with early stage breast cancer. Do I apply adjuvant this? Do I apply adjuvant that? What's your risk if I do this? If I don't do it, what are the side effects, et cetera? And we didn't, even though we have 2 randomized studies that showed a benefit with LEN, you don't see a lot of people using LEN, for high-risk smoldering myeloma out in the community. Now, DARA is different because the side effect profile is more favorable, so it's more likely to get more widespread adoption. But I think if we do the education right, I think that the community oncologists will apply it for the right patients.
What are we going to tell them? We can't agree. What do we educate them to say? Well, I don't think any of us know what to do. I'm playing devil's advocate a little bit, but I struggle with it because I don't think any of us know what we're going to do with this data yet. And are we waiting for something for it to mature to say then we're going to do? No, I don't think so. So I don't.
Well, the formal survival analysis, not enough. We have a survival signal, which is favorable, but this was not a pre-planned survival look, right? So once they have enough survival events that they can do the formal analysis, if there is a survival advantage to the use of DARA
So
in this patient population,
Kids presenting it.
I think it'll happen sooner than that. But that would be a game changer, I think.
So Pete, out of curiosity, if all the patients in observation arm had received CD38 antibody, do you think you would have seen the survival advantage?
Yes.
Oh, wait, say that again?
If everybody who progressed in observation arm had received CD38 as second at the first line, whatever you want to call, do you think you would have seen the survival advantage? I don't know.
So that's a great question. I think, we have to recognize that when this study was conducted, that a lot of these countries didn't have CD38 antibody therapies available for newly diagnosed patients, right? So that's one of the reasons why they weren't applied, but they would have been applied in the subsequent therapy, right? Because you had availability. So I think, whether it's in the next line of therapy or the one after that, these patients will get CD38 antibody-based therapy in the observation arm. So I think that the survival data will still be compelling.
And the PFS2 is encouraging, right? When you guys looked at the PFS2, and that seems to be longer.
Yeah, that's right. The problem with, the people that have progressed are truly the higher risk patients. You know what I mean? The patients that progress later, are going to do better, obviously, regardless of what you treat them with.
Yeah, so, in the last couple of minutes, I want to take a step back. So, so this whole journey from MGUS to smoldering to active myeloma, we've been chipping away at including the ultra high risk smolderers into the myeloma, active myeloma definition. But that has been more of a disease burden based decision after seeing, all right, 80% or more of these patients are going to progress anyway in the next 2 years, so let's include them in active myeloma, make sure that it's been replicated in different data sets. But that slide you showed about Francesco's futuristic view, that paper was a review 6 years ago. But we actually now have data that you either have genomic myeloma or you have genomic MGUS. And yes, the immune profiling plays a role in that transition, but you know that there is tumor from the onset. So will we ever get to a point where we are actually using that profiling to just say, all right, it doesn't matter if this patient is symptomatic or not, they have cancer. They might have early cancer, and I might need to treat them only for 5 or 6 months, but they'll be cured, versus someone who is coming in with a higher burden disease because that's when they were diagnosed, and you're giving them a different recipe to get them to that cure. Will we ever get there? This is a futuristic question to you. Will we ever get to a point where we're saying, all right, this is just MGUS, this is myeloma, we know it, it's just, little burden, we only need to give such and such treatment. Will that happen in our lifetimes?
I don't know that we're ever going to get to a point where we can dichotomize like that, where you've got MGUS and active multiple myeloma.
Stay tuned, there's a paper coming.
And nothing in between. Well, but even if we do decide to do that, there's going to be a lot of heterogeneity in that active multiple myeloma group, from a genetic perspective. Data that was published, I think it was last year, in Ola's high-risk smoldering myeloma studies, showing the genetic complexity was not as profound as it is with active multiple myeloma. So there is, so you could argue it a couple of ways. You could say, well, were these really high-risk patients? Or you could also argue, high-risk smoldering myeloma is not necessarily the same thing, genetically as, active multiple myeloma. So I just, it's a spectrum, of evolution, right? I don't think we can make that cut. And there's going to be patients that benefit from less aggressive therapy. Everyone's worried about undertreating patients with single-agent DARA, but we use single-agent DARA in amyloidosis all the time, for example. There's plasma cell biology that's problematic that we do treat less aggressively than our standard myeloma patient. You know what I mean?
And the other factor to consider, I think, is the trials that were set up to potentially cure smoldering myeloma with that hypothesis of less genomic complexity, lower burden of disease. The two that have been done, phase 2 studies, albeit the CESAR as well as the ASCENT study, do not really provide a lot of support for the idea that you can, at least with those approaches, those patients are progressing at about roughly the same rate.
Just like myeloma. They behave,
I know,
treat them like
that's
myeloma, and
correct.
they're relapsing exactly like myeloma.
That's right.
Yeah.
So I do think that I'm not sure that we will be able to cure patients with smoldering myeloma with just starting treatments 6 months earlier or a year earlier. It doesn't. And then I don't think we can justify starting treatment 7 years before it. So I think that I don't think we will see curative approaches yet with what we know now of smoldering myeloma and the treatments available for them.
All right. The last comment I have before we close the session. So, one of my concerns with doing studies without having that genomic or immune information is you may be giving treatment to a lot of genomically MGUS patients, right? So you're really not selecting out the real patients where you would have had that randomized study to see the impact.
No, the genetics definitely need to be incorporated into our definition for sure, because there's patients with high-risk smoldering myeloma who are truly active. And this is where, at least in clinical practice, that 6-month window of observation to see how they're behaving is so important. And there's patients who clearly have MGUS genetically and can be taken away from that high-risk smoldering myeloma and not offered treatment. So we can do a much better job at defining it.
All right.
So hopefully, the future trials will be designed based on this genomic risk than disease burden risk, right? So I think that might be one good way to.
All right. So we'll take one question. Can we get a mic to Aditi here? And then maybe after this question, we can close.
Thank you so much. That was a great session, actually, with a lot of good insights. I just wanted to, get your take on, clearly DARA is one of the most active therapeutic agents you have in myeloma, and clearly it sounds like most people want to save it for when patients actually have active myeloma. And given that you see like an inflammatory signature in your precursor stages, right, like MGUS or smoldering myeloma. As an MDS physician, I feel like I'm thinking about like trials we're doing for, say, CHIP, CCUS, low-risk MDS, which are really anti-inflammatory. You know, we have agents like canakinumab targeting IL-1 beta. We have luspatercept. You know, we have IRAK targeting drugs. Does this make more sense, you know, to just maybe save your, you know, your really good myeloma drugs for when the patient has active disease and really targeting inflammation in the precursor stage in multiple myeloma too? Or what is your opinion on this kind of approach in myeloma? Is it being done anywhere? Thank you.
So those kind of, you know, small studies have been done in the past. You know, we are participating in a study with leflunomide as an example, you know, but I don't think that we've really seen a change in the trajectory of smoldering to active myeloma progression in those kind of experiences. I think it's more like an immune escape, you know, so you have like this certain threshold at which the genomic myeloma cells just proliferate, and then you start seeing this immune paresis phenomenon and T cell exhaustion. Those patients still have the CD8 positive cytotoxic T cells. You know, it's just that, you know, in terms of functionality, you don't see them. And so, you know, that's my take. I think that's one of the reasons why, you know, using short courses of bispecifics, you know, has been attempted.
Yes. No, I agree. I think Irene Govril has done the single-cell sequencing studies on healthy bone marrow patients and then MGUS smoldering early. So clearly there is a clear distinction of immune dysregulation happening as you go forward from the healthy to MGUS to smoldering. So as you rightly pointed out, I think this immune escape happens. But what triggers the immune escape is either genomics or is the body's immune system. We really don't know. And that is the critical point to understand, you know, what made this clone to go from like, you know, completely asymptomatic to myeloma.
In fact, I think, you know, David Farrow had done spectral flow many years ago to show us that, you know, hot versus cold immune environment and active myeloma went back in the Levine days.
I just wanted to plug the ultimate anti-inflammation diet. My colleague, Dr. Shah, is running studies of that, which I think is a great way to intervene in these early precursor states, is to modify, you know, things without using more drugs. I think is a good way, a good approach for some of these precursor states. So.
Yeah, the session wouldn't be complete unless we mentioned that or the microbiome. So now the session is done. So, all right, thank you so much.